एक बात बताइए, इसका लिंक शेयर कर देना प्लीज, पेजेस ज्वाइन कर।
हाँ लिंक शेयर
ये लिंक कैसे कॉपी होगा? किसी एक पे व्हाट्सएप पे भेज दीजिए, इसी आईडी ये लिंक आपको उनको शेयर कर दीजिए।
हाँ मैं कर
मैं
दूँ।
सबको
आप स्टार्ट कर दीजिए, ऑनलाइन हो गया।
ओके ओके
Yes,
ओके।
sir.
A very warm welcome and good morning to all of you. And I welcome to all the chief guests, distinguished participants and friends. Today we are here to celebrate our 10th workshop, which is being held for last 10 years, and it is the 10th one. And it is the hard work of Dr. Rahul Bharat, who has brought a new guide and new light in this field. तो मैं आपसे बस यही कहना चाहूँगा कि इनकी मेहनत के लिए मेरे पास एक शेर मैं शेयर करता हूँ। सफ़र में धूप तो होगी, जो चल सको तो चले। सफ़र में धूप तो होगी, जो चल सको तो चलो। सभी हैं भीड़ में, तुम भी निकल सको तो चलो। तो डॉक्टर राहुल ने ये प्रोग्राम आज से 10 साल पहले किया था। हमारे पास है बच्चों के ये जो न्यूरो डाइवर्सिटी के फील्ड में जो भी नॉलेज है उसको हमें शेयर करना चाहिए, और हम इंडियन चिल्ड्रंस को, भारतीय जो बच्चे हैं उनको हेल्प कर सकें, आगे बढ़ा सकें। और उन्होंने सिंगल हैंडेडली इस प्रोग्राम को 2014 में गोमती नगर में शुरू किया था, और ये अकेले ही कारवां लेकर शुरू हुए थे, और आज इनका एक बहुत लंबा कारवां हो गया है। और अपने ही देश में नहीं, दूसरे देशों में भी, आप समझिए लंदन में भी और दुबई में भी हमारे सेंटर्स खुल गए हैं। उत्तर प्रदेश के 4-5 सेंटर हमारे ओपन हो गए हैं। तो सबसे पहले हम लोग चाहेंगे कि डॉक्टर राहुल को एक जोरदार तालियों के साथ स्वागत करिए। थैंक यू। तो ये जो हमारा वर्कशॉप है आज, ये बड़ा यूनिक वर्कशॉप है। यूजुअली जो वर्कशॉप होते हैं वहाँ पर डॉक्टर्स होते हैं, और डॉक्टर्स के बीच में ही इंटरेक्शन होता है, एक्सचेंज ऑफ नॉलेज होता है। बट डॉक्टर राहुल का ये विजन है कि नहीं, हमें जैसे कि हमारे पेरेंट्स संतुष्ट हो सकें। ऐसा ना हो कि वो किसी एक प्लेटफॉर्म पर गए तो कोई दूसरी बात की गई, दूसरे प्लेटफॉर्म गए तो उनसे तीसरी बात की गई। वो ऐसा अगर होता है, एक डॉक्टर ने कुछ कम्युनिकेट किया, दूसरे डॉक्टर ने उसी बात को दूसरे ढंग से कहा, उससे तो पेरेंट्स परेशान हो जाते हैं, और उनके पास ना ज्ञान नहीं होता है, सोर्स ऑफ नॉलेज जो अब वो चले जाते हैं गूगल पर, तो वहाँ कुछ और उनको मिलने लगता है। तमाम प्रोफेशनल्स लोग भी हैं वहाँ पर, वो अपना ही विजन शेयर करने लगते हैं। तो देयर इज लॉट्स ऑफ कंफ्यूजन इन क्राउडिंग इन द माइंड कि क्या करें, कैसे करें, क्या सही है, क्या करें। इसी को ध्यान में रख करके हम लोगों ने यह प्लान बनाया कि नहीं, अब हम अकेले डॉक्टर्स का वर्कशॉप नहीं करेंगे, हमारे टीचर्स और हमारे जो है साइकोलॉजिस्ट और डॉक्टर्स सब लोग एक प्लेटफॉर्म पर आएँ, और हम एक्सचेंज ऑफ नॉलेज करें, जो भी लेटेस्ट है, एविडेंस बेस्ड है, उसको शेयर करें, और हम अपने कम्युनिकेशन को इतना स्ट्रांग करें कि पेरेंट्स समझ सकें कि वास्तव में व्हाट इज़ द रूट ऑफ द प्रॉब्लम। यूजुअली होता क्या है, न्यूरो डाइवर्सिटी के फील्ड में या न्यूरो डिसिप्लिन के फील्ड में जो प्रॉब्लम होती है हम उस पर काम करने लगते हैं, विदाउट नोइंग दैट आवर होल बॉडी इज कंट्रोल्ड बाई आवर ब्रेन, एंड वी आर नॉट अवेयर अबाउट द डेवलपमेंट ऑफ द ब्रेन। डॉक्टर राहुल ने जो ऐप डेवलप किया है उसकी यूनिकनेस यही है कि हम ब्रेन की डेवलपमेंट के स्टेज को पता कर लेते हैं, और जब हम ब्रेन की डेवलपमेंट के स्टेज को पता करके पेरेंट्स को कम्युनिकेट करते हैं कि देखो बच्चा भले आपका 5 ईयर का हो गया, 4 ईयर का हो गया है, बट योर चाइल्ड इज एट 1 ईयर ऑफ एज या 1.5 ईयर ऑफ एज, तो पेरेंट्स को सेटिस्फेक्शन मिलता है। अच्छा ये कारण है। यूजुअली क्या होता है कि बच्चा 1.5 साल का है तो चलना चाहिए। नॉर्मली क्या होता है, the persons who are working in this field they start trying to walk this child, उसको चलाने के लिए पूरा प्रयास करते हैं। ऐसे में क्या होता है, बच्चा परेशान हो जाता है। अब जिस बच्चे का ब्रेन अभी 6 महीने का है वो 1.5 साल का काम तो नहीं कर सकता है, और हम उसके शरीर से काम ले रहे हैं कि बच्चा 1.5 साल का है तो 1.5 साल का काम करे, चलना चाहिए। तो बिना बैठे ब्रेन हमारा स्टेप वाइज पैटर्न में डेवलप होता है, स्टेप बाई स्टेप। जो बच्चा बैठ नहीं पा रहा है किसी हालत में चल नहीं सकता, और अगर चलाने की कोशिश की गई बैठ ना पाने का मतलब उसका ब्रेन अभी 6 मंथ का ही डेवलप है, अभी 6 to 7 मंथ पर ही हमें जाके काम करना है। लेकिन हम अगर उसकी फिजिकल एज को रख करके ध्यान में रख के काम करेंगे तो डेफिनेटली हम 1.5 ईयर का काम कराएंगे उससे। तो हमारी पूरी बॉडी ब्रेन से कंट्रोल होता है। अगर ब्रेन की स्टेज को हमने नहीं समझा, केवल फिजिकल एज को समझ करके ही हमने काम किया, तो बच्चा परेशान होता है, पेरेंट्स परेशान होते हैं, और जो बच्चा है उसमें कुछ बिहेवियर ऐसे आने लगते हैं कि पेरेंट्स परेशान हो जाते हैं। अब उस बिहेवियर को फिर वो मैनेज करने लगते हैं कि सर अभी देखो ऐसा करने लगा है, अब तो बच्चा भागने लगा है, कूदने लगा है, चीखने लगा है, चिल्लाने लगा है, बाइटिंग करने लगा है, तमाम तरह के सेकेंडरी बिहेवियर्स आते हैं। हमारा कहना है कि हम सभी लोग इस बात को समझें कि हमारी पूरी शरीर हमारे ब्रेन से कंट्रोल हो रही है, और हमें अगर कहीं भी बच्चा पिछड़ता हुआ दिखता है, फिजिकल या साइकोलॉजिकल या मेंटल, तो हमें बच्चे की ब्रेन की डेवलपमेंटल स्टेज को ही पता करना है। और जब हम वहाँ जा करके उस लेवल पर काम करना शुरू करते हैं तो डेफिनेटली वी गेट द रिजल्ट, एंड दैट इज द लॉन्ग टर्म रिजल्ट। हमारा बच्चा आगे चलकर भी अपनी जो चैलेंजेज हैं उसका सामना कर पाता है और उसको बहुत अच्छे से फेस कर पाता है। तो आज का जो कार्यशाला है, वर्कशॉप है, जहाँ पर हम एक्सचेंज ऑफ नॉलेज तो करेंगे ही, इसके साथ साथ हमारा एक विजन डेवलप होगा, हमारा एक वे ऑफ कम्युनिकेशन डेवलप होगा, जिसको हम पेरेंट्स से आगे बात कर सकेंगे। कई बार हम टीचर से बात करते हैं, स्कूल में जाते हैं कि बताइए आप जो बच्चे स्ट्रगल कर रहे हैं इस फील्ड में, पढ़ाई लिखाई फील्ड में, आप हमारे पास क्यों नहीं भेज पाते? तो वो कहते हैं कि सर हम कैसे बोलें, बड़ी झिझक है, कैसे कम्युनिकेट करें, पेरेंट्स हमको बोलेंगे कि आप हमारे बच्चों को ऐसा क्यों बोल रहे हैं। तो मुझे लगा कि कहीं ना कहीं ये वे ऑफ कम्युनिकेशन की बात है, स्किल ऑफ कम्युनिकेशन की बात है, जो डेवलप करने की आवश्यकता है। और ऐसा नहीं है, सभी पेरेंट्स अपने बच्चे से प्यार करते हैं, टीचर भी प्यार करते हैं, और जो डॉक्टर्स हैं बच्चों के वो भी बहुत प्यार करते हैं। हम सभी बच्चों को प्यार करते हैं, लेकिन ऐसा कुछ ना करें कि बच्चे का नुकसान हो जाए उस प्यार में। तो प्यार तो करना ठीक है, लेकिन बच्चे की डिफ़िकल्टी को समझना, बच्चे की डिफ़िकल्टी को समझ करके उस पर काम करना भी हम सभी लोगों की जिम्मेदारी है, जिससे कि वो बच्चा अपने को अलग थलग ना महसूस करे। जब वो बड़ा हो, समाज में इंटीग्रेट हो सके, मेन स्ट्रीम स्कूल में आ सके। जो फाइनल टारगेट हमारा होना चाहिए वो यही होना चाहिए। हमें शॉर्ट टर्म गोल को नहीं अचीव करना है कि बच्चा नहीं बोल पा रहा तो बुलवा दो, नहीं चल पा रहा तो चलवा दो, ये नहीं टारगेट रखना। हमें ये रखना है कि बच्चा जब हमारा एडल्ट हो जाएगा, मेन स्ट्रीम स्कूल में आ जाएगा क्या, फैमिली में एडजस्ट कर पाएगा क्या, या समाज में एक रिस्पॉन्सिबल सिटीजन बन पाएगा क्या, ये हमारा लॉन्ग टर्म गोल होना चाहिए। तो हम लोग यही देखेंगे कि कैसे करें, पेरेंट्स से कम्युनिकेट कैसे करें, हमारे टीचर, हमारे डॉक्टर, सभी लोग, कि पेरेंट्स को पूरी बात समझ में आए। इस वर्कशॉप का यही सबसे बड़ा एम है कि हाउ टू डेवलप कम्युनिकेशन। नॉर्मली वर्कशॉप में क्या होता है कि नॉलेज का बहुत एक्सचेंज होता है, और राइट फ्रॉम MBBS टू द पोस्ट ग्रेजुएट और सुपर स्पेशलिटी तक बातें की जाती हैं, थियोरिटिकल, बट प्रैक्टिकल बातें हो नहीं पाती। और जब प्रैक्टिकल बात आती है तो डॉक्टर घबराते हैं कि अब अच्छे इसको करना कैसे है। कई बार मैंने भी बहुत से वर्कशॉप ज्वाइन किए, सेंट्रल IEP के भी किए, स्टेट IEP किए, तो एक्सचेंज ऑफ नॉलेज के लेवल पर तो दे आर गुड, बट एजुकेशन कैसे हो, हाउ टू कम्युनिकेट विद द पेरेंट्स, हाउ टू डील विद द पेरेंट्स, वहाँ पर प्रॉब्लम आती है। हाउ टू एस्टेब्लिश ए गुड चाइल्ड डेवलपमेंट सेंटर, वहाँ पर प्रॉब्लम आती है। तो आज हम लोग ये सीखेंगे कि कैसे हम कम्युनिकेट करें और कैसे हम आगे बढ़ें। यहाँ पर हमारे जो लीड फैकल्टी है वो डॉक्टर राहुल भारत हैं, और उन्होंने अपना ट्रेनिंग पूरा MBBS करने के बाद लंदन से किया है, और उनका स्पेशलाइजेशन इस फील्ड में है। तो वी आर लकी टू हैव डॉक्टर राहुल। थैंक यू डॉक्टर राहुल। एंड वी हैव क्लिनिकल साइकोलॉजिस्ट डॉक्टर उजैना, and she is working with us for last 10 years also. And we have Dr. Namrata Agrawal and Dr. Pramod Nayak from Gorakhpur. They are working in this field for last 1 year, and we hope we will do better in future also. तो मैं आप सभी लोगों का बहुत आभार व्यक्त करता हूँ कि आप लोग अपना वैल्यूबल टाइम निकालें। और डॉक्टर हमारे अब्बास साहब बैठे हैं यहाँ पर, जो कि कभी भी लाइव के प्रोग्राम में आ नहीं पाते हैं, तो हम विशेष तौर पर उनके आभारी हैं कि उन्होंने आज के प्रोग्राम के लिए समय दिया, और सुबह से ही समय दिया। इन्होंने अपनी OPD क्लोज कर दी। और सिंधिया मैडम है हमारी, जो सीतापुर का एक बहुत रिप्यूटेड हॉस्पिटल है, वहाँ उस हॉस्पिटल को संभालते हैं। मैम थैंक यू मैम, आपने समय दिया और आज आना है, थैंक यू सो मच। और इन्हीं बातों के बाद मैं सोचता हूँ कि हम लोग आगे बढ़ें, टाइम कम है, एंड वी शुड प्रोसीड फर्दर। थैंक यू।
Good morning, everyone. Now we are going to start with the oral presentation. And may I request Dr. TR sir and Uzana ma'am to come and join and be the chairperson. And Dr. Abbas. So now we will start with our first presentation. May I request Dr. Vishali Chauhan to come and join and start with the oral presentation. And the timing for oral presentation is 7 minutes. And 7 minutes for presentation and 2 minutes for question answer. 12 minutes for presentation and 2 minutes for question answer.
Good morning, all of you present here and respected faculty members. I am here, Dr. Vishali Chauhan, from the Department of Pediatrics from Kare Institute of Medical Science, presenting on the topic assessing the stress level on primary caregivers of children with cerebral palsy, under the guidance of Dr. Zainab Abbas, our head of the department. Cerebral palsy is a disease spectrum which mainly involves neurodevelopmental deficit, where brain's ability to control movement and maintain balance as well as posture is hampered. Cerebral palsy is a permanent and static disease, mainly occurring secondary to hypoxic insult on developing brain and manifest by childhood or early infancy. Various risk factors existing either during prenatal, natal or postnatal period will contribute to development of cerebral palsy. Prematurity, hypoxic ischemic injury during the prenatal period and certain intra-infantile infections are some major events to be blamed. Cerebral palsy tends to cause intellectual disability and various milestones delay. These children are not able to do their daily life chores like bathing, dressing and cleaning, and even not able to eat or care themselves. Apart from what the child may suffer, a huge suffering comes for the caregivers of these children. These caregivers experience different challenges in their day-to-day life. Learning how to train an intellectually disabled child is a task in itself. These caregivers many times have to give up on their jobs and social life to raise or nurture their child. The caregivers need to be vigilant all the time to tackle with any distressful situation which can arise through their care procedure. However, the primary issue is that nobody acknowledges the mental health of these caregivers and their experiences or the mental fatigue they deal with on the daily basis. My study material method will be study design is cross-sectional study. Place of study was Kare Institute of Medical Sciences and Hospital. Duration was August 2024 to October 2024. Enrolled population, I have taken 50 caregivers of children with cerebral palsy. Data retrieval from the OPD and IPD reports. Study procedure. After taking an informed consent, a thorough history was taken, including the demographic information like age or sex, birth information, type of cerebral palsy, gross motor function classification system for grading of cerebral palsy. The caregivers were provided with a modified short Zared burden scale questionnaires, comprising 15 questions with each 0 to 4 for each question. Total score ranges from 0 to 60, in which 0 to 12 had no to mild burden, 12 to 24 mild to moderate burden, and more than 24 score is high burden. Result, I have taken in my enrolled population, I have noticed that 80% were parents, 16% were grandparents, and 4% was first degree relatives. I have also classified under the modified Kukuswamy scale, in which 2% were upper middle, 10% were lower middle, 56% were upper lower class, and 32% was lower class. And most of the enrolled population were dealing with the spastic type of cerebral palsy. And I've also classified the cerebral palsy patient under the gross motor function classification system, in which I noticed that class 4 or 5 cerebral palsy patient had no burden or stress level on the caregivers. And most cerebral palsy had developmental delay, seizures, and feeding difficulties, but only 32% were on the anti-epileptic medication. And I have classified my caregivers under the modified short Zarit burden scale, in which 16% has low to mild, 16% had high, 20% has low to mild, and 64% had mild to moderate short burden on the caregivers. Conclusion: caregivers with cerebral palsy patient experience mild to moderate level of stress. Factors like developmental delay, seizure disorder, and feeding difficulties among the patient are significant cause for caregiver stress. On the other hand, poor socio-economic status, lower level of literacy, and various socio-cultural disbeliefs among caregivers are to be blamed for their stress. Discussions like author DA et al. 2022 study discussed but concluded healthcare workers should provide early and proactive planning of medical and social support for children with cerebral palsy and their family using a family-centered approach. And Ramanandi VH et al. 2022 study concluded that joint families were reported to be the source of pressure and time crunch. Economical stress is one of the most common reasons for parenting difficulties, especially for parents of disabled children, and has been controlled with higher level of prenatal stress, parental stress, distress, anxiety, depression, and caregiver burden. And further study also concludes the same thing. Key home messages: always remind that the caregivers that even though their kids will never be considered normal, they have the potential to be exceptional. Help the caregivers to help themselves. Groups can be formed online or near the hospital where they can communicate and discuss their everyday struggles in a safe environment. In the last, it's not a one-person job, and the whole family should contribute in the providing the care to patients with cerebral palsy. Thank you.
Excuse me. Myself Devendra Mishra. I have some one questions. I am a little bit confused. Cerebral palsy is a disease or disorder? You are mentioning like it's a disease.
Not a disease, it's a disorder. And it can be like, if you treat them very well, like counseling, you should do the counseling and the treatment. It can be like, and conclusion the last now, the child can never be normal, but it can be exceptional.
So cerebral palsy is a disability. So disability means where the child do not have the physical capacity to do something. Disorder means that the physical capacity is there, but the child will not do it because that's an impairment because of turbulent situation. And disease means that there is a pathogen that you can treat. So that's why it's a disability rather than disease.
I have a question to you. So the biggest problem in cerebral palsy is parental expectation. So what happens is that most parents are trying to normalize their child. So it's like pushing the wall. And if you do that, you'll get tired quickly. So the goal for a medical professional is to have a sympathetic communication. So I usually show the MRI to parents and say that these wires have broken, which cannot be repaired. It's like a finger has been cut, so it will not grow back. But early on, if the child is stimulated in the right way, so what is the right way of stimulation? So let's say you have a 2-year-old who is not sitting. So the child's core has not developed. That's why he's not sitting. That means the brain has not developed the pathway to control the bigger muscle. And let's say the child is not sitting, the parents want the child to walk. I always see parents, they will make the child stand and they will hold the leg and make the child. Nothing good will come out of that. The core will not develop. Even the child will start walking, they will walk with a big limb, they will develop scoliosis, they will develop respiratory complications, all of those things. Sorry, I'm barging to your paper. But very important is you give the bigger picture. So cerebral palsy is a journey. So when you have that journey, you will have difficulty with tone. Developmental achievement is only one goal. But the expectation you should set is that, okay, most children will walk in 1 year. Your child, you should extend the walk. Let it take long, work on the tone, work on the posture. So that later on, you have better connected child in the brain and better outcome. That's the only way. So people are doing the wrong thing. They are trying to really push the wall. They are trying to have wrong goals of achieving the milestone early. They are falling into a false trap to say, okay, I'll make your child walk in 3 months. I'll make your child walk in that's not going to happen. So very, very important. And then again, the GMF classification is very important. So based on the brain injury, if you have GMF 4 and 5, expectations are different, disease burden is different. So those all things should come in the communication of doctor. So later in the conference, I will talk about my app where we have all this information. Any more questions?
Yes, sir. One.
Hello, good morning. It's an interesting topic which you took for the presentation. My first concern is, have you taken all the diagnosed individuals, cerebral palsy, which you're doing it for caregivers? So is it the individuals are all diagnosed?
Yes, ma'am, it is all diagnosed.
All diagnosed. Okay, and you targeted only the caregivers. What about the family members?
I have taken the primary caregivers, like it can be grandparents, like who's caring like the primary one, who is the more close related to the child.
Okay. So have you done the psychoeducation workshop kind of thing to the parents or the caregivers, because they need to understand what this disability is?
Like first priority is counseling the parent, that not to compare their child with the normal, with the other children. First I have done the counseling, and then I have I have communicate with them how to care for themselves, because they are very stressed. What should they do, and they are not caring, and they are financially also depressed. So I have counseled them कि आपको उनका भी ध्यान रखना है और अपना भी ध्यान रखना है. And family members also भी एक पर्सन की जॉब नहीं है, सिर्फ उन्हीं को, सिर्फ मदर को, मोस्टली मदर्स ही होती है केयरगिवर्स, तो हमें सिर्फ मदर को ही नहीं बोलना है कि मदर ही केयर करेंगे. आपको मतलब पूरी फैमिली को सपोर्ट करना चाहिए.
So have you started doing with some of the strategies or some of the methods which you have actually told them?
Strategies like we can make the offline groups in a hospital. Like one day we can give to the cerebral palsy patient and the caregivers, and we can make a group like offline also. And in the WhatsApp group, we can make a group of their caregivers, and they can do any activities with the child, and they have to post on the group. So it will encourage the other person also. We should also do the same thing. Or उससे stress level कम होगा, because they will be happy doing all this thing, because today social media is growing so much, and they will be their stress level will somewhat lower down.
Thank you.
Anyone else?
Sir, I was using the modified Zaric burden scale,
वो हमें दे दो.
in which there was 15 questionnaires, and I was doing the item survey. Every question I was asking the parent, and they were marking it, and then that is a pre-approved test.
Thank you very much. It was an excellent presentation. So we go to the next one. Unfortunately, this lab
Yeah.
is very information for our
ऑडियो बाद में ये लगाओ,
Dr. Richard.
पावर देखो.
Today I am going to present on the topic barriers to early diagnosis and treatment delay in children with autism.
भैया बताओ जो कुछ बताना.
My presentation
Power
is on
audio.
I'm from the Department of Pediatrics and King George Medical University, Lucknow. Autism spectrum disorder is characterized
India, prevalence of 1% in 2 to 6-year-old and 1.4% in 6 to 9 years old. Mean age of autism spectrum disorder diagnosis was 4.4 years according to a study in USA, and mean diagnostic delay was 2.2 years. The delay between the emergence of the signs and symptoms of autism spectrum disorder and the diagnosis is worth noting. Early intervention may have long-term benefits for child functioning and family life. Most of the parents recognize autistic features in their child by the age of 3 years, but only 2/3 seek professional help by this age. The objective of the study was to determine the barriers to early diagnosis and treatment delay in children with autism spectrum disorders. It was done in KGMU. Children with autism in the age ranging between 18 months to 12 years at outpatient department of pediatric neurology and child psychiatry. It was conducted from October 2022 to March 2024 for the observational study. Inclusion criteria were children of all gender in the age range of 18 months to 12 years, children fulfilling the DSM-5 diagnostic criteria of autism, and parents willing to give informed consent. Exclusion criteria: children having symptoms of only global developmental delay or an intellectual disability, and children requiring priority management at the time of assessment. Study flow: total 160 children were screened. Enrollment of cases was done in pediatric neurology and child psychiatry once in 2 weeks at alternate weeks to prevent bias. 20 children they got excluded because they were fitting the exclusion criteria. 10 had global developmental delay, isolated intellectual disability 8, and patients requiring priority management 2. A semi-structured questionnaire was used to record the socio-demographic and clinical details. For the qualitative component, semi-structured in-depth interviews were conducted in Hindi with the primary caregivers of 140 children with the diagnosis of autism. Interviews ranged from 30 minutes to 1 hour in duration. Data was collected and the results were then analyzed. The observation was that the age of appearance of the first symptom, the mean age was 1.92 years. And the age of presentation to the doctor, the first time the parents visited the doctor, was 3.45 years. So the mean time delay in diagnosis was 1.63 years. The age distribution of the study sample: most of the children in the study sample were in the age group of 5 to 8 years, and then they were 49.28%, and then the second group was 1.5 to 4 years, 33.5%. Most of the cases we had seen in my study sample, 72% of them were males, and only 28% were females. Distribution of the study sample on the basis of their socio-demographic status: most of them belong to upper middle class according to modified People's Economic Scale, and lower middle socio-economic status. I had taken the sample of 140, and 96 out of 140, that is 68%, were from urban areas, and 32%, which is 44 out of 140, they were from rural areas. So most chunk came from the urban areas. Causes of delay in diagnosis and treatment: I had taken a questionnaire and then the results were analyzed. The result was 95 out of 140, around 67%. The maximum patients had the financial burden. That was the most important cause of delay in diagnosis and treatment. The second was lack of knowledge and education. So even after the first symptom, they didn't have the knowledge and education that the child is having a problem. They should visit a doctor. They visited the doctor late. So lack of knowledge and education was at the second number. And then there was also lack of access to diagnostic services. Most children who were from peripheral areas, they had lack of access to diagnostic services. After it almost took them 6 months, 1 year, 2 years, 3 years to move from peripheral areas to the bigger cities for the diagnostic services. And 40% faced social stigma. First source of awareness about autism. Most of the patients, most of the caregivers, they got the information about autism from their doctor. From social media, 33%. From their friends and family, 21% and 33%. So the study sample, I studied 140 patients. So number of patients not taking therapy were 56%. So even after the diagnosis was made, only 44% of them were taking therapy. And out of the children who were taking therapy, 87% of them were taking therapy in a private sector. Occupational and speech therapy they were taking in a private sector, and only 13% were taking in a government sector. Number of now this is my data. Number of patients on therapy who had delay in initiation of therapy after the doctor advised therapy. 72% caregivers there was a delay in providing therapy to their children. Number of attendants who saw improvement in their child after taking therapy. 83% of them they felt that after therapy they have seen improvement. Number of families who migrated for taking therapy for their child. Most of them had migrated to Lucknow from distant areas in Uttar Pradesh. 24.1% had to migrate. Stress in caregivers, almost 75% attendants, the caregivers were stressed. Attendants who felt that therapy is expensive and causes financial burden, 67.86%. And families there were also certain families where a parent had to leave their job. Most of the cases, the mother had to leave their job. 12.86% cases, the mother had to leave their job. Discussion. In our study, the mean age of appearance of this first symptom was 1.92 years, and the average time delay in diagnosis was around 1.63 years. There was a study, Bhagnani et al. 2021. In their study, also there was similar delay, 1.5 year delay between parental concerns and autism diagnosis. According to them, lack of awareness in parents and caregivers about the age-appropriate child developmental milestones is apparent amongst the community and health professionals. We found out that among families of patients, lack of knowledge and education, 50%, and financial burden, 67.86%. They were the most significant barriers to access diagnostic services and treatment.
Gmail password.
According to Patel AD,
इसको
caregivers of children with ASD suffer from high burden of care and impaired quality of health. Also, the caregivers belonging to low-income families have a high burden. The study also highlighted that the quality of life worsens with the severity of autism spectrum disorders. Conclusion. Many caregivers wish to start occupational and speech therapy for their children, but are unable to start because of the lack of government services in the peripheral areas of the state. Most mothers have to tirelessly take care of the child all day and night. Many working mothers, 12.86%, had to leave their job. The prevalence of stress in caregivers included in our study was 75%. There is a need for initiatives that address cultural barriers and stigma, as well as for increasing the research in this area for more understanding of the factors causing delayed diagnosis and treatment of children with autism and how best to deal with them. There is a need to increase the government facilities for providing occupational and speech therapies to these children to decrease the financial burden on the caregivers. In a developing country like India, not all families can afford to migrate to bigger cities for having access to the therapy. Strengths of the study was a prospective observational study. Inclusion and exclusion criteria was strictly followed. Study was well planned and carefully done. Sample size was sufficient. Annotations for the study was done at a tertiary care center. So many known cases were referred cases.
Any questions? Dr. Acha, very nice presentation. My question to you that do you have any comparative data of different risk factors rural
जैसे उनका
versus
खत्म हो बोलो एनी क्वेश्चन
In my that how many were from rural and how many were from urban.
have you asked the risk factor or and compare the
ये माइक चल रहा है
rural versus urban?
वहाँ माइक है उस माइक को
According to the study, according to the data that I have collected, the rural patients they had more difficulty, and according to the data, the rural patients they had a longer time gap between the first symptom and the diagnosis time. And the urban cases, most of them are from Kanpur, Lucknow, Bareilly, Agra. So most of them, in those cases, the diagnosis was made earlier as compared to the rural cases.
And one more thing that you mentioned that one of the most common cause of the delay in the diagnosis of PSC is the lack of this, the financial burden. But what we observe in most of the cases, and Dr. Rahul sir and his team, Dr. Yadu sir, they are speaking the masses. It is the lack of awareness among the healthcare providers that are actually causing the delay. What we are observing today. So I think this is a new thing that we should go and research this topic as well.
In this study also, they said that in the Bhattani and 2021 study, they had also pointed out that there is appropriate time development milestone apparent among the community and health professionals.
Yes, it is very significant that the lack of caregivers and about this one. Yes, this is the most important factor we are facing in our students. Whatever you finding, you have, this is the statistically significant. What do you say?
Because the study, sir, it was an observational study, so sir, there was no comparison. But there was no comparison.
So very interesting presentation. I would like to know that what tool did you use for diagnosis?
For diagnosis, I had used the Intrain. We use Intrain. So for the surgery, we had used NCR, and for diagnosis, we use Intrain.
And so in the presentation, the data analysis had very less percentage of parents and children who were going to the government sector. So what do you mean by the government sector?
Yes, ma'am, there is a therapy when we see these children in home, and then we advise them therapy, speech therapy, and occupational therapy. So in my study, most of the cases that I saw, they were preferring a private institute for the therapy. There are many therapy centers in Nagar. So most of them are going there only. There is a government therapy center in KGM also, there is a KIC, and there is one on Complan Road. But only 13% were using it, and they were very dissatisfied with that. So most of the patient attendants were satisfied with the private therapy centers, but the only concern was that the private therapy centers are so expensive that it was taking them 500 rupees each day, and they go 7 days a week. So approximately a lot of it was a financial burden, but most of them belong to middle socioeconomic sectors and also higher economic sectors. So they were going.
Just one last question. So is there any specific reason of developing speech therapy and occupational therapy in children with autism? Because I mean, see speech therapy is not such a problem, is it?
Goal-oriented, we can do, but there is definitely that what sir also pointed out that amongst the health professionals also there is a lot of dilemma that what should we do. So there is a very lack of awareness among the health professionals also. Yes.
Thank you, Dr. This was a nice presentation. I just want to ask you, can you please tell me if someone cannot afford this help, what you can advise them?
Ma'am, definitely when patients, attendants come and they are not able to afford,
healthcare provider, we should have a clear mindset that it is not the only way, or I would say it is not the way. Okay? So look forward. Yes, ma'am. Thank you.
So I'm doing the hosting again. Next presentation is Lindsay and Neurodiverse.
It was 11 morning. I was in my cabin and I had just completed and conducted an EDIR assessment. And a parent, a mother, she asked me, "Ma'am, क्या मुझे अपनी family से अलग रहना पड़ेगा बच्चे के लिए?" And to be honest, at that given moment, I didn't have the answer to give to her, to cater to her need. And that's when I decided, yeah, I want to see whether this family structure has a role to play in the outcome of the intervention. So this is what we've done together. My name is Lucy Baptish. She's my fellow lead, Purnima Mishra. The study is titled as The Influence of Family Structure on Parental Stress and Child Severity Outcomes in Early Intervention Programs for Neurodiverse Children.
Good morning, everyone. As I just introduced myself already, my name is Ms. Purnima. So, coming to the neurodiversity. So, what do you mean by neurodiversity? Do you have any answer? Okay. So here, first introduced by sociologist Dr. Singer, neurodiversity advocates for viewing these differences as a part of human diversity rather than a medical problem. So whenever we are talking about the neurodiversity, the first thing that comes to our mind, that is autism. So what do you mean by autism? Okay, so the autism, that is, according to DSM criteria, the autism, that is a difficulty in social interaction and social communication, wherein it is also defined that the children, they have a strong likes and dislikes, basically restricted repetitive activity and reciprocity is absent. So here we have some family structure, that is a single parents, nuclear family and a joint family. So a single parents means basically a mother, all-rounders,
Nuclear parent with two guardians and joint family. Nuclear parent with two guardians and joint family with two or more couples. Affect parental stress and child severity outcomes in early intervention programs. So the hypothesis that was taken was, does family structure has, the hypothesis taken was family structures playing significant influence on stress reduction in parents and an improvement in child severity scores during intervention. So the methodology, we took a sample of 75 families with autistic children. The data was retrieved from the GeniusLane data pool and from all the different centers, and we categorized them into three different groups: single parent families, nuclear families, and joint families. The independent variables that were taken were family structure and early intervention program treatment that was applied. The dependent variables were parental stress and severity scores. So parental stress just refers to the strain and psychological pressure that a caregiver would experience while raising the child. Thereafter, multivariate analysis of variance, which is ANOVA, as suggested by my senior, was used to examine the effect of early intervention on parental stress and severity score. And the duration was taken for 12-month period, the intervention program that happened to be on the children. The time duration was 12 months, and thereafter we were able to get to some conclusion. The main effect of time says that It shows a large reduction in parental stress and child severity from pre and post intervention across family structures. So the implication is that the program led to a substantial improvement over 12 months. So the program that we give at GeniusLane showed that there was a reduction in pre and in parental stress and child severity. The next main effect of family structure showed a significant main effect of family structure shows that different family types experience variations in stress and severity. The implication would be the family structure contributes to changes in parental stress and severity, though not as strongly as affected of child. The interaction between time and family structure suggested that the rate of change in stress and severity differs by family type. So there was a significant result that happened to come after the analysis that family structure does play a role, but as keeping that forward, there was not a major substantial data that could say that it has a major role to play in how the intervention would be. Another result in terms of how the parental stress and child severity improvement can be seen among the different family types. The nuclear family showed highest reduction in parental stress, and for child severity improvement, joint families experienced the greatest improvement in child severity. And the implications, as mentioned in the slide, family structure influences the effectiveness of interventions. With nuclear families benefiting most in stress reduction in joint families, achieving the greatest gains in child development outcomes. So more or less, the study showed that we do have an impact of family structure, but not really significant. On the other hand, it showed that nuclear families have, with time, the time given 12 months, show a great, the highest reduction among all the structures in terms of parental stress. And in terms of child severity, we can see in the duration of 12 months, children with joint families showed greater improvement. So the takeaways, like I said, there was a significant conclusion made, but that is not the absolute answer to the question to the parent that had asked me. कि क्या मैं फैमिली से अलग रहूँगी तो क्या मेरे बच्चे में वो इम्प्रूवमेंट दिखेगा जो मुझे करना चाहिए. So to that parent, now when I have to answer her, well, family structure may have a role to play, but on the other hand, the more important aspects of any intervention program is to, firstly, like my fellow presenter said, psychoeducation, so understanding the resultant diagnosis of the given diagnosis of the child is the first thing that plays a major role. Then comes support and communication, so how the parents support each other, or how the parents are provided with support, and how do they share responsibilities, and also in terms of what background they are of. Like in the other presentation, she mentioned how socioeconomic status also has a role in the intervention.
Limitations for sample size and diversity. So basically, the sample of 75 families and may limited to generalize area of the research. And it was a short-term focus. So the 12-month period will not reflect a long-term effect because I believe that the research can go on. Also, uncomfortable confounding the factors. So basically, the factors like socio-economic status, the ancestral
अब आने लगी मुझे
influence the result, and the cultural specificity, the results culture setting, the limits of
स्लो ही आएगी स्लो है ना
the difference cultures and family dynamics.
इसमें तो आ रही है
Before we conclude, Dr. Tia started the interaction with a share. I would end with my presentation. I had written that कहीं नहीं कोई सूरज धुआं धुआं है फिजा, खुद अपने आप से बाहर निकल सको तो चलो, सफर में धूप तो होगी जो चल सको तो चलो, सभी है भीड़ में तुम भी चल सको तो चलो. So the idea is how you understand the resultant diagnosis that will make an impact to the child's life. Thank you.
Any questions?
So if you go back to your slides. Yes, sir. So we have said child's severity improvement. So can you please tell the audience how do we calculate child severity in autism?
So at our organization, we take an assessment, we call it as software assessment, which has a lot of aspects to it, so 24. We look into how the child is on all of those parameters. So it has aspects of listening and attention, play, speech, reading, writing, self-regulation, understanding, and all of these parameters are taken into consideration while we, during the software assessment, we just play around with the child, have interaction, and see how the child lies in terms of play, and then after do the scoring. And the severity is then accumulated through the software made by the organization. I hope I can answer your question.
Is that clear to everyone who doesn't know much? Is that clear? What did you say, or should I explain? Clear? Explain? Okay, so in any child, there is functionality. That is the developmental milestone. The child is sitting, walking, talking, changing their dress, not using nappy, read, write, all of those. This is functionality of the child. That depends on their developmental age. So when a child with autism don't meet their developmental milestone, there is a panic. And people want them to meet their developmental milestones. But the severity of autism depends on only three things: restricted activity interest, repetitive behavior, and reciprocity. So, what Lindsay has said actually takes it strongly into consideration the DSM-5 and ICD-11. And the biggest study for that was done in Harvard, which reported outcome measures in autism. So we have integrated that, and that is also the national UK policy, that all children with autism is not their functionality, but how restricted they are. So let's say they are not talking, there is no problem with the mouth. If there is a problem with the mouth, then it's a different diagnosis. But neurodiverse autism child, problem with talking with the mouth is a restricted behavior. So they might not be talking, but later on they might be talking. So they might be too little or too much. So that's very important to understand that you are dealing with the restricted repetitive behavior, which is going to make the alternative pathway in the brain. If those pathways are made, then later on child will have a disorder. Yeah, that was my question. Thank you so much.
Yes, you presented very nicely about this study, but my one question that you have any data in your study, that any comparative data about those, you compare the data of nuclear and joint and other parts. Do you have data those who are joining the outdoor activity and those who are confined to the home? Do you have any data?
This was just the starting to what I see as my current question. I like starting the conversation that this was something that I wanted to look into, and like you said, I take that as a suggestion. As for now, train more.
Because I am one of the part of your team, just in a locality, and what we observe, and because parents, their caregivers are the best informed, they are the best observer for the child's activity and milestone, say. And some parents come to us and they say that, sir, वो तो हमने पहले therapy बहुत कराया, but हमने play group में डाला, then बच्चा now is doing well. So that's why I asked the question. Do you have any comparative data about this? No.
very nice presentation, Nancy. I just want to ask you that you have told that nuclear family showed the greatest improvement in parental stress, while joint family showed greatest improvement in child severity. So, is there any confounding factor, or why such is happening?
There are compounding factors, as in
Yes, we had talked about that in the limitations. There were some confounding factors, uncontrollable confounding factors. That could be economic status of the family. So, if for example, if the family is of parents who both of them are educated, well educated, and now know and understand the diagnosis, so of course in the intervention the result would be different. But to a family who comes from a place where they are yet to understand, and as well as उनकी as for now education जो है वो इतनी नहीं है कि वो समझ पाए the complexities of the diagnosis. So उनके साथ of course you have to start from scratch, but again that also plays a role. So socio-economic status, their family background, if they come from a medical family background, they'll have more idea in terms of, well, it can have its own pros and cons, but yeah, all right.
क्वेश्चन था कि मैडम का बहुत वाजिब क्वेश्चन है ये कि न्यूक्लियर फैमिली में ज़्यादा इम्प्रूवमेंट देखा गया है और जो हमारी जॉइंट फैमिली है उसमें इम्प्रूवमेंट कम देखा गया है। क्वेश्चन इसलिए बट आंसर इन इयर्स में तो जो फैमिली पूरी होल फैमिली इज वर्किंग एज अ टीम देन देयर इज ए बट इफ देयर इज ए कंफाउंडिंग फैक्टर जैसे इंडिकेट किया कि बहू की बात सासू नहीं सुन रही है, या इफ देयर इज पैरेंटल हार्मनी, मदर तो कर रही है लेकिन फादर ही नहीं इसमें इन्वॉल्वमेंट, देन दीज आर द फैक्टर भी बढ़ जाता है। हां, दैट इज फैक्टर इज आल्सो दैट इज अ कंफाउंडिंग फैक्टर आल्सो। तो जो क्लियरिटी है वो है कि इफ वी नीड ए क्लियर डायरेक्शन एंड देयर विल बी ए टीम, होल फैमिली इज वर्किंग एज अ सिंगल यूनिट, देन वी हैव
Please may I ask you to give the Minty which is coming, yeah, this one, so that because finally there is a prize for best oral presentation based on the scores. So please give your Minties. Thank you. Okay. Very good. So the next presentation is Microsoft Edge. By Riya Kapoor, who has a presentation for us. Thank you.
Namaskar everybody. Thank you for coming today. And my name is Riya Kapoor. I am a PhD scholar at Christ University, Delhi NCR. Along with that, I work with one of the schools in Dwarka, Delhi, as a special educator and a psychologist. Obviously, we have two roles because in one we can't justify the school. So that's that. So here I have my first slide. So I want to ask, can you read this? Is it readable? What do you read?
Specific learning disorder.
Congratulations, you know how to read and you know how to use the phonics and everything. But do you know what is specific learning disability? Any idea? So I wanted as specific learning disability to move to specific learning disability. I first want to introduce my title, which is a small part of my PhD research, it says integrating the expanded core curriculum in individualized education plans to address comprehension, reading, and executive functioning deficits in a child with specific learning disability, a case study. Alright, so I'm using the term specific learning disability because it is written in RBWD Act. That is why I'm referring to that, but yes, as Sir said, that it is specific learning impairment. Okay, so specific learning disability is a neurodevelopmental disorder. It's one of the neurodevelopmental disorder which is characterized by persistent difficulties in learning and using academic skills such as reading, writing, mathematics. Along with that, it needs, even if the intelligence is okay, there are a lot of difficulties that these children face. Now, the challenges are usually related to language, auditory, and visual information. Along with that, it is mostly related to academic performance and self-esteem of that child. The confidence that is shattered once the child has reached a certain age where the child starts using his or her brains. Now, before proceeding to the methodology part, I want you to understand what expanded core curriculum is. So expanded core curriculum is basically a curriculum framework which is used for visual impairment students. And it is something that, in India and in abroad, everywhere people are using expanded core curriculum for visually impaired students, but in the blind schools only, not in the inclusive classrooms. But today, we are including children with disabilities in an inclusive school and making the schools inclusive, if I were to reframe, right? So expanded core curriculum has 9 areas. 9 areas are compensatory skills, career education, self-determination, assistive technology, independent learning skills, sensory efficiency, recreation and leisure, orientation and mobility, social interaction skills. These are the 9 areas. And if you see, these 9 areas are something that our children with neurodevelopmental disorder also require. These are 9 areas which can also have a great impact and help children with neurodevelopmental disorder effectively. Now, to test this, I just tried including this in my individualized education plans. So individualized education plans help me out. It's a 3-month plan, it's a 1-week plan. According to the need of the child, we develop a plan. But again, on what terms are we developing that plan? If I tell the parent that okay, your child has this, and you got the assessment done from a clinical psychologist because I can't do the testing. You get the testing done from a clinical psychologist, and once that testing is done, we are going to do the further things which is through individualized education plans. But how? What am I doing with those individualized education plans? I work on the strengths and the weaknesses, that is the traditional method, and I prepare a plan which I follow in school, and if parents want to, they can follow at home. If not, that is also fine. Now, the researchers that support, I used to support my study hard, one of the researchers said that ECC is an important tool as a curriculum framework to help children with disabilities, no matter if the child is from visual impairment, hearing impairment, or any neurodevelopmental disorder. Along with that, there are studies which have stated that standardized assessment should be done. Along with that, early intervention and intervention of any kind needs to be done with neurodevelopmental disorders, specifically for specific learning disability, because the intelligence is intact with them. Intelligence is not hampered. Even if it is hampered, it can be improved with early intervention and other things. Now, I'll quickly move to the methodology part. The objective of the study is to explore how integrating expanded core curriculum with an individualized education plan can address comprehension, reading, and executive functioning deficits in a child diagnosed with specific learning disability. The design of the study is, I have used a single case study design, employing a qualitative, in-depth approach to examine the intervention's impact on the child's academic skills and executive functioning. The study uses both quantitative and qualitative tools to assess the child's abilities over time. So time series analysis is also being used here. Now, participant is a 12-year-old female who studies in grade 7, and she has been diagnosed with specific learning disability. Again, I convinced the parent to first get the diagnosis done so that I have a pathway to what should be my next step. Because without diagnosis, I cannot deal with students of disabilities into school. So that is one criteria that I had to follow. Now she was first referred to me by her class teacher, and she's the child who never speaks. And I thought that the child might be a case of selective mutism, or the child is shy, the child is conscious, everything like that. And when the diagnosis came, the intelligence came at at power of 85, which is a slow learner category. Along with that, selective mutism part was ruled out because the clinical psychologist said that there is no selective mutism. The child knows how to speak and the child will speak. It's just that we should know how to proceed further. Now, she has been identified as a suitable candidate for intervention that combines the principle of ACC with her IEP. Why? Because I did not take many children here because this child was a special case. Special case, how? She was somebody who loves to stay among people and who loves to understand the vibe of people, but doesn't want to speak, doesn't want to participate. If anything comes up to her, okay, you tell me, okay, Ria, you tell me how will you explain this? She goes blank. Okay, Ria, you tell me this. She goes blank. So any participation thing that was required, she was blank. Anything that required her attention, okay, you have to make a choice, this or that. Blank. Nothing, no communication as such. So I tried, so as I'm a certified psychologist as well, so I thought that, okay, I should give her some time, and I take once a week sessions, and let's do behavior therapy with her. Let's try something, let's make individualized education plan, and we should try that. I tried behavior therapy, I tried cognitive behavior therapy, I tried, other things as well. Nothing worked. I was like, okay, a 7th grader would love some reinforcement. Be it playing on phone, be it playing anything, or any kind of reinforcement for that matter. The child was blank. The child was like, I don't want all of this. And I was really taken aback, but at the same time I was like, okay, you are a good challenge for me. Let's work out. Okay, let's figure out how should I make you speak? How should I make you include in this particular environment and make you reach your highest potential? So here comes my study. I collected data through DDLE, DDRD, and executive functioning scale, and I also used participant observations, feedback from parents and subject teachers, and I used review of student performance reports as well. Data analysis was reflexive thematic analysis and comparison of scores obtained from standardized tools before and after intervention. So this is a sample individualized education plan which I wanted to show. So here, the first component is assistive technology. So assistive technology, so when I just created here, just for the reference, I have created suppose a goal, right? So whenever required, the child will be able to use assistive technology tools independently to support reading comprehension, spelling, and basic calculations with 80% accuracy. Now, what kind of assistive technology the child is going to use, right? So here, I reduced these individualized education goals to the smaller parts, which was first reminder and scheduling as speech-to-text software, audio books, calculator use. Because the child was diagnosed with specific learning disability. So here the child was mostly towards dyscalculia and dyslexia side. Dysgraphia was not there, so dyslexia and dyscalculia. So here the child didn't know how to read. She had strong dependence on the sight words. So anything that starts from F is either from or for. So there is nothing in between. So if I say Ria travels from this, so she will either read from or for. All right. So that was one thing. The one thing with her. So now assistive technology helped me out. In schools we have smart boards, right? In smart boards there are calendar scheduling. So calendars are like, okay, they help the child understand. So because it's an inclusive school and children with autism likes to be prepared. Okay, what is the next period? What is the next period? And what to be expected and what not to be expected. So the scheduling has to be done. So for that, she was made the scheduling monitor. There she was able to she was able to use assistive technology there where she had to communicate. So there was no choice with her. Okay, I am giving you a choice whether you speak or not speak. You have to speak because you have to schedule, and without speaking to the teacher, you cannot schedule. So that was one area. And then in the same way, I did with career education. So in career education, I helped her develop a career interest booklet. She has a scrapbook now in which she just takes cutouts and pastes things. That okay, this I can pursue as a career. This I can do this. Again, not communicating verbally, but through the other means. So like this, I created for all the 9 domains. All the 9 domains here. Alright.